Hello, in this video we are talking about psychological disorders. So the first thing we're going to do is talk about some definitions. What is a psychological disorder? What are some of the ideas for where they come from? And then we are going to break down certain categories of psychological disorders like mood disorders, schizophrenia, personality disorders, anxiety disorders, and look at them a little bit more in depth. But first, again, we are going to do some definitions for psychological disorders. The first one, what is a psychological disorder? It is a condition characterized by abnormal thoughts, feelings, and behaviors. Psychopathology is the study of psychological disorders. This includes things like your symptoms, your etiology, which is the causes of the disorder, the treatment. Psychopathology can also be the manifestation of a psychological disorder, how it presents itself. And so when we talk about what is a psychological disorder, there are a couple of definitions. The first one is the behaviors, thoughts, and inner experiences that are atypical, distressful, dysfunctional, and potentially dangerous. When we talk about atypical, that means something that deviates from the norm. Another definition for psychological disorders is behavior or inner experiences that differ from widely expected cultural values and expectations. When we talk about cultural expectations and values, what we're talking about is what is considered accepted behavior in that culture, because what is considered accepted can vary from culture to culture, even within different areas within one culture. For example, do you smile at strangers, or is that considered rude or odd? Do you make eye contact with people, or is that atypical? You can also see cultural norms that change over time. For example, Freud thought an assertive woman was someone who had a psychological disorder. This was not typical. It was a sign of a fixation from a psychosexual stage. In current Europe and the US, totally acceptable for a woman to be assertive, not a sign of a psychological disorder. So within cultures and across time, you can see changes in what is considered disordered. When we talk about dysfunction, one way to think about it is Wakefield's idea of harmful dysfunction. So a definition of psychological disorder that was created by Wakefield looks at natural internal mechanisms, which are psychological processes like cognition and learning, that help us experience the world like other people do. So dysfunction is when these mechanisms, these internal mechanisms, break down, they don't function normally. And this breakdown, this dysfunction, has to lead to negative consequences for the person or for other people. So you have to have significant internal anguish, and it has to create problems in your day-to-day living. That is how Wakefield would define a psychological disorder. For example, Joe has a fear of heights. He quits his job when the company moves to the top floor of a building because he can't handle looking out the window at work. That would be, according to Wakefield, a psychological disorder. It's a dysfunction because the internal mechanism, the fear, isn't working correctly, is too large, and there are harmful consequences. He has to quit his job. So there's a lot of different ways to think about what is a psychological disorder. We're going to kind of be focusing on Wakefield's idea. When we talk about these psychological disorders and what is a psychological in general, what it is, another type of definition is what the American Psychiatric Association would call a psychological disorder. The American Psychiatric Association is also called the APA, which is what the American Psychological Association is called. It can be confusing. This chapter, we're talking about the American Psychiatric Association. They say that a psychological disorder is a condition that has significant disturbances in thoughts, feelings, and behaviors. These disturbances reflect some sort of psychological, biological, or developmental dysfunction. The disturbances lead to significant distress or disability, and the disturbances don't reflect expected or culturally approved responses to certain events. That is what you have to have in order to be diagnosed with a psychological disorder. If you want to know all the disorders you could be diagnosed with here in the US, you have to look at the DSM-5-TR, the Diagnostic and Statistical Manual of Mental Disorders. It is in its 5th revision, and that 5th revision has had sort of a mini update, a text revision. That's what the TR stands for. So that came out very recently, the TR part of it. The DSM-5 came out, oh gosh, it's been, like 7 years, 7-8 years. It's been a few years. So the DSM first came out in 1952, and it was based on the diagnoses that the U.S. Army was giving out in World War II. So it was based on a format from the U.S. Army from World War II. So the DSM-5, actually no, 2013 is when the DSM-5 came out. So it's been almost 10 years. So the DSM-5 came out almost 10 years ago. The DSM-5-TR came out 2022. So a whole lot more recently. And the DSM has categories of disorders. So all the disorders you can be diagnosed with. And it has the diagnostic features, which is basically an overview of the disorder. Here are all the symptoms, or here's an overview of what it is. And then it has the diagnostic criteria. Those are the specific symptoms you're required to have to be diagnosed. And it can be things like, you have to have one of these 2, and then 3 of the following 5. It depends on what the disorder is, on how many of these symptoms you have to get the diagnosis. It will also tell you the prevalence, the US prevalence for the disorder, and risk factors for the disorder, what makes it more likely you will get it, as well as comorbidities. And a comorbidity means there's a co-occurrence of 2 disorders. So, this is totally made up. This is not an actual comorbidity. But something like 17% of people with an anxiety disorder also have a substance abuse disorder. That sort of thing. So if you have this, here are the chances you also have this other disorder as well. Actually, another example of a comorbidity that is true, 41% of people who have OCD, obsessive compulsive disorder, also have major depressive disorder, one of the mood disorders. 60% of people who have a substance use disorder also have some other disorder as well, whether it be a mood disorder, schizophrenia, whatever. So you see the comorbidities. Another diagnostic tool is the ICD, which is in its 10th edition, ICD-10. That is the Internal Classification of Diseases. This is published by the World Health Organization. So it's international, it's not for the US. And this was also published about the same time after World War II. The differences between the DSM and the ICD is used more for clinical diagnosis, but it also measures the general health of populations and the prevalence of a disease internationally. The DSM is used more for research. It's used clinically within the US, but also internationally for research. The ICD is more international. So for example, like the prevalence rates in the DSM are based on the US. They're not based on international reports. ICD is more global. We are going to be focusing on the DSM because this is a US psychology class. Okay, so one thing we're going to do as we go through these disorders, we're going to, not so much the supernatural one, but for biological and the diathesis stress model, we'll talk about for different disorders, here's what someone from this perspective would say contributes to the chance you have this disorder. So when we talk about what is causing this disorder, sort of an old school perspective one, well, still exists a little bit today, is the supernatural perspective, which is going to attribute the psychological disorder to a force beyond scientific understanding. It is the devil, it's an evil spirit, something like that. This was more common in Europe and the US a few hundred years ago. Think about like Salem witch trials. It still can be found in some places today. For example, when I was working in Rwanda, I was at a meeting with a lot of genocide survivors. I mean, it was hot, it was crowded, people were singing. It was a big kind of sensory overload event. And someone started to have a flashback, a post-traumatic stress disorder flashback. Screaming, sort of laying on the ground, having a traumatic experience. And so as a psychologist, I'm thinking it's PTSD, it's a flashback, it's all the loud noises, it's bringing back memories. We need to get them to a quiet place and help them deal with this psychological episode. Some of the people that were there at the event thought that it was a demon trying to possess the person, and they needed to lay hands and pray on the person to get rid of the demon to stop this event. That is going to be a supernatural perspective. It is something that science can't handle. It's something supernatural. Again, for the most part, there's not a whole lot of people that follow that route, but it still does exist in some areas today. You can have a biological perspective. This is going to see psychological disorders as linked to biological phenomena. So this is going to look at genetic factors, chemical imbalances, brain abnormalities. This is going to look for things like traumatic brain injuries. This is going to study postpartum depression by looking at hormonal imbalances. This is going to look at your genetic predisposition for schizophrenia, those sorts of things. And then you have the diathesis stress model. This is going to look at, this sort of comes from the psychosocial model. So this is going to look at learning, stress, faulty thinking, environmental factors. For this model, this is going to combine biological and those psychosocial factors to predict the likelihood of a disorder. So it says that people who have an underlying predisposition for a disorder, that is the diathesis part, your predisposition for a disorder, are more likely than other people to develop a disorder when they are faced with adverse environmental or psychological events. That's the stress part. So you have this predisposition that combines with some sort of environmental or psychological event that causes the disorder to develop. So both factors are needed for the disorder to develop, the predisposition with the environmental component to it. So as we go through these disorders, we are going to look at how someone from a biological perspective would look at it, how someone from the diathesis stress model would look at it. We're not going to focus on the supernatural part so much. So I'm going to talk about anxiety disorders first. And first part for that is, what is anxiety? So when you are thinking about a potential threat, or you're faced with a potential threat or a negative event, anxiety is going to involve apprehension, avoidance, and cautiousness towards that event. When you have anxiety, it can motivate you to act or to avoid certain things. You might have an anxiety disorder if your anxiety is excessive, if it is persistent, if it is out of proportion to what the actual threat is. So the main definition for an anxiety disorder is characterized by excessive and persistent fear and anxiety, and by related disturbances in behavior. Overall, the lifetime prevalence for anxiety disorders is 25 to 30%. In a 12-month period, 23% of women and 14% of men will experience an anxiety disorder. It's the most common form of mental disorder. There are different types of anxiety disorders. One type is specific phobia. Specific phobias are excessive, distressing, and persistent fear and anxiety about a specific object or situation. You realize your level of fear is irrational, but you still might go to great lengths to avoid the stimulus, to avoid the thing you're afraid of. There are several types of specific phobias. I'm just going to mention a few. More than this exist. For example, acrophobia is a fear of heights. Aerophobia is a fear of flying. Trypanophobia is a fear of injections. Agoraphobia is a fear of a situation in which it would be difficult to escape or receive help if you have a panic attack. That is very specific. That is also listed as a separate anxiety disorder in the DSM-5-TR. It's technically not listed under the specific phobias, but it is a phobia. So, why do they develop? A researcher named Rachman says that there are 3 learning pathways for phobias, 3 ways you learn a phobia. One is classical conditioning. So, for example, like little Albert being afraid of the white rat. That's a phobia of a rat. Classical conditioning. You can also learn phobias through vicarious learning. So if someone is afraid of heights and they act very afraid by heights, and so their kid learns you're supposed to be afraid of heights, so you can kind of pass down these phobias, vicarious learning. And also verbal transmission or information. Someone says, you are supposed to be afraid of this thing. So someone teaches you, this is what your phobia should be. He says we're less likely to develop fears to things that are actually more dangerous. And one reason for this could be evolutionary. So for example, you're much more likely to have a fear of dogs than you are to have a fear of motorcycles, even though motorcycles kill a whole lot more people than dogs do. But back in the day, 1,000 years ago, motorcycles didn't exist. Dogs did. So it's easier to develop a fear of things like dogs, things like spiders, things like snakes, rather than things that are actually more deadly. We sort of have this evolutionary predisposition to develop a phobia for things that used to be the most common dangerous things for us. The next type of anxiety disorder we're going to talk about is social anxiety. And social anxiety disorder is extreme and persistent fear or anxiety and avoidance of social situations in which you could potentially be evaluated negatively by other people. For the prevalence rate, 12% of Americans will develop social anxiety disorder in their lifetime. So that's the lifetime prevalence rate. A big part of social anxiety disorder is a fear that you are going to act in an embarrassing way or show signs of anxiety, like you'll start sweating or get red in the face, or do something that leads to rejection. And so common situations that can lead to social anxiety are things like public speaking, meeting strangers for the first time, even things like eating in restaurants or having to use a public bathroom. And people with social anxiety disorder tend to have lower educational attainment. They tend to have lower salaries, lower work performance, higher unemployment, and higher dissatisfaction with friends and family. So those are all things that can come if you have social anxiety disorder. People with social anxiety disorder also tend to engage in safety behaviors. And safety behaviors are mental or behavioral acts that reduce anxiety in social situations by reducing the chance of negative social outcomes. For example, if you know you have to be at a party and so you say you'll help make sure all the food's getting ready in the back, so you don't actually have to be interacting with people in the front. You wear boring, neutral clothes so you don't stand out. You make sure you don't work out before you go to a party because then you'll be red and sweaty before it even starts. Those sorts of things. People with social anxiety disorder are also more likely to have an alcohol use disorder. You can kind of see this as self-medicating. They use alcohol to try to reduce anxiety, but then that can lead to another disorder itself. Some risk factors connected with social anxiety disorder, who is more likely to get it. Part of it is your upbringing. If you were severely teased as a kid, you are significantly more likely to develop social anxiety disorder. 92% of people who were severely teased as kids, or 92% of people with social anxiety disorder say they were severely teased as kids. Another risk factor is behavioral inhibition, and this is a consistent tendency to show fear and restraint when presented with unfamiliar people or situations. This is thought to be inherited, so this is a genetic thing that tends to be passed down. If you have behavioral inhibition, if you tend to be afraid of new things, unfamiliar things, you have 7 times the chance of developing social anxiety disorder compared to people who do not have behavioral inhibition. So that is social anxiety. The next anxiety disorder to go over is panic disorder. Panic disorder is when you have recurrent and unexpected panic attacks. So what is a panic attack? It is a period of extreme fear or discomfort that develops abruptly and reaches a peak within 10 minutes. So when you have a panic attack, this can involve things like you have a high heart rate, you're sweating, you're trembling, you feel like you're choking, you get hot flashes, or you get chills, you're dizzy or lightheaded, you feel like you're losing control or you're about to go crazy, you think that you're about to die. A lot of times people who have panic attacks go to the ER because they think there is something seriously physically wrong. In order to be diagnosed with panic disorder, you have to have at least a month of a persistent concern of additional panic attacks. So you have to have at least a month where you're worried you're about to have a panic attack. You have to worry about the consequences of a panic attack. You also have to have self-defeating changes in behavior related to the attack. So you change your behaviors, you change your lifestyle in a negative way to try to avoid attacks, things like avoiding exercise. And oftentimes people with panic disorder develop agoraphobia as well. because they're worried about having a panic attack in public and not being able to leave that situation, not getting help for their panic attack. There are risk factors that make it more likely you will develop panic disorder. It's partly genetic. You also have some parts of your brain that play a part in this. For example, the locus coeruleus is in the brain stem, and it releases norepinephrine. Norepinephrine is connected with your fight or flight response. And so if you release too much of that norepinephrine, it can trigger a panic attack. Classical conditioning can play a part in this as well. So you can have a classical conditioning response to subtle sensations in your body that resemble what happens when you're scared. For example, your heart starts to beat fast. It might beat fast for a totally separate reason, like you just walked up a flight of stairs. But you don't register that heart rate as coming from the stairs. You think, oh my goodness, maybe I'm about to have a panic attack. And then that can lead to the onset of a panic attack. It can also be something like asthma. So people who have asthma are 3 times more likely to develop panic disorder than people that don't. You get a slight shortness of breath. You think you're about to have a panic attack or an asthma attack. That gets you scared, and it leads to a panic attack. And then there can also be cognitive factors. People with panic disorder interpret normal bodily sensations catastrophically. And then that triggers the attack. So normal sensations in their body, they assume are signs of something seriously wrong, impending doom, and then it leads to their panic attack. So there's several risk factors that can lead to it. The final thing I'm going to go over to in this video is generalized anxiety disorder. And then we'll start the next video with the final anxiety. I don't know, actually, there's a couple more anxiety disorders we're going to go over. We'll start the next video with OCD, but that's a longer discussion, so I'm going to start the next video with that. We will finish with generalized anxiety disorder here. Generalized anxiety disorder is a relatively continuous state of excessive, uncontrollable, and pointless worry and apprehension. So you worry about everyday things, even though you know your concerns are unjustified. It is less severe anxiety than panic disorders, but it's more continual anxiety. You have what is called free-floating anxiety. This is actually a Freudian term for worrying and apprehension that's kind of always there. So if you're going to get diagnosed with generalized anxiety disorder, your anxiety cannot be connected to another disorder like panic disorder. And it has to occur more days than not for at least 6 months. And it has to be accompanied by 3 of the following symptoms: restlessness, difficulty concentrating, being easily fatigued, muscle tension, irritability, and sleep difficulties. So you have to have at least 3 of those things. The lifetime prevalence, so the chance sometime in your lifetime you will get it, is 5.7%. So it is not very common, but it is more common in women. It's twice as likely in women as in men. And there is a high comorbidity between this and other anxiety disorders and mood disorders. Also, if you are diagnosed with this disorder, it tends to be chronic. It's not something where you have it for 1 year and then it's gone forever. It tends to be something that stays with you. If you have this disorder, you're more likely to have a heart attack or a stroke. You're always feeling slightly stressed, increases the chance of those disorders. Certain risk factors for it, it's partly genetic. Biological perspective, it's going to be genetic. There is something called the cognitive theory, which says that worry helps you avoid powerful negative emotions. And so there is a strong correlation between childhood abuse and the development of generalized anxiety disorder. So by continually worrying a little bit about everything, it keeps you from having to focus on something really horrible. So childhood abuse is a risk factor for this. And that is where I will stop this video. We'll start the next video with OCD.